have to put up with me twice in one day. Even my kids don't want to do that. I would hear it from them, but it's a privilege to be here again twice. And obviously, this was a topic that we had first initially planned, and then I stepped in for Dr. Carey to honor his award. Let's go ahead and start. Jennifer already introduced me, but for the sake of time, that those of you who don't know me, I'm an internist. I'm a primary care generalist, even though I've done a lot of cardiovascular research and stuff. But really, at the end of the day, I didn't want to do cardiology or endocrine or nephrology when I was a resident doing internal medicine at Boston. So I was going to go out and do general medicine, et cetera. But they had a very superb, world-renowned vascular group and hypertension group there. They knew of me. I had done some research at Penn State when I was a medical student, and they asked me to come as a fellow. It wasn't really a fellowship, but they were just basically hiring me for wages to be a hypertension fellow, and that's how I got into hypertension. But I never lost my general medicine and my primary care thoughts, credentials, et cetera. And I've been involved in residency programs throughout my career in internal medicine, et cetera. So I just wanted you to know a little bit about that. You don't know who's always up here. What are they about? I still see patients. I saw general medicine patients on Tuesday morning, and then hypertension patients on Tuesday afternoon before coming here on Wednesday. This is interesting, and it's kind of by happenstance. One of the programs that I've been on the leadership of, it's called the Hearts Program, the Global Hearts Initiative. And in the Latin American and Caribbean area, it's called Hearts in Americas of the Pan American Health Organization, a subset of the WHO. And I've been involved with them for 10 years. And our goal is to control hypertension to 80 to 95% globally, period. And we've embarked in 2013. And we're 10 years into that journey. And believe it or not, it's been wildly successful in terms of the number of countries coming on board, and we're implementing it more and more and more. Why do I tell you that? It's because, like all organizations, and it's really an honor to follow Pregna Patel. We were together, initially started the Hearts Program together. Then she went on to the communicable disease division in her role as the CDC. She was in the non-communicable disease division when I first met her. So it's an honor to follow Pregna. But like Pregna said, COVID happened. And we had been going to visiting these countries, meeting their prime ministers or their presidents or whatever the title, their health ministries, et cetera, and implementing Hearts and trying to get them to have ownership and maybe embark upon it. And many of them did. But COVID stopped everything. We couldn't travel, of course. Travel was non-existent. We did as best we could with Zoom meetings, et cetera. But that 3 years, it didn't stop the program, but it sure slowed it down because we couldn't visit. Well, we're now out of it. This year, we just came out of the COVID. We had our very first Hearts meeting in the Caribbean with 26 countries. And now it's opened up travel. In fact, Monday I go to Guyana to spend a week with them in terms of starting and implementing their Hearts program. And the head of the PAHO, Pan American Health Organization, asked me to give this talk or something similar to this talk at our very first meeting together when we reconvened after COVID. And we hadn't reconvened in 3 years. And it was a unique idea. And it was, COVID disrupted everything. And the question was, well, maybe COVID disrupted our knowledge base in hypertension. Have we really seen, has everybody really seen any of the important clinical trials? Have we discussed the results, its implications, et cetera, during this 3-year period? So Pedro Ordunez, Dr. Ordunez asked me to convene a group with me as a one group and look through the literature over the last 3 years and see if I could detect or define any sentinel or seminal articles that we may or may not have missed, but we clearly didn't discuss because we weren't in communication, we weren't in person. So I gave this talk in St. Lucia last month, and it seemed to be a really, really big hit. But nevertheless, that's where it came from, and I want to give credit where credit is due. It wasn't my idea. I was just told, okay, I'll do it. But here's the reason, and it's wonderful to follow Pregna. COVID disrupted everything. But I'm on the NCD, which is non-communicable disease component, if you will, since I'm an internist and deal with hypertension and vascular disease, et cetera. And we published this paper right in the middle of COVID. As you can see, the citations on the bottom was 2020. And it was to sound an alarm. Not only was COVID horrendous as a communicable disease, and Pregna showed all the data that we experienced, but it was horrendous for the non-communicable disease world too. It was tremendously disruptive, and we coined the term the co-pandemics between COVID-19 and NCDs, non-communicable diseases, predominantly cardiovascular disease, since it's the #1 morbidity, mortality risk factor worldwide. And we published this paper called The Perfect Storm. Well, what was it about? Well, first of all, we had the acute COVID pandemic. That would be bad enough. But then the interruptions and disruptions for resources, manpower, people, et cetera, had to shift overnight. Remember? Obviously, we all do. It's embedded in our brain. That disrupted other disease states, not just hypertension, Alzheimer's disease, dementia, mental health. We could go on and on, right? But certainly it disrupted cardiovascular disease management, particularly hypertension. We were following hypertension control rates, and they were plummeting within weeks to months after the initiation of the COVID pandemic. That exacerbated the chronic NCD pandemic globally further. That increased the hypertension burden more. And if that wasn't bad enough, we've got the other side of this curve, and that is that increased comorbidities with COVID, because hypertension, Pregna mentioned diabetes, obesity, et cetera. Those were major risk factors in addition to age, which is not modifiable. And if anybody can figure out if it is, would you tell me first? But that then increased the pandemic further, increased COVID morbidity, mortality, and it became a vicious cycle. Thank goodness, hopefully we're partially interrupted this cycle. We're not out of the woods, but that's why we pay so much attention to it. And we published a paper in integrated blood pressure control in the middle of the COVID pandemic, sounding the alarm that it wasn't just a communicable disease, it's disrupting these are non-communicable diseases as well. Another theme during the studies we're going to talk about is this theme. And this comes right out of the Heart's playbook. In my lifetime, we talked about the renin-angiotensin system this morning. There was none, then there was one, and then there was ways to inhibit it that are now elegant. Well, there was no hypertension care in my lifetime. I was told when I was a medical student at Penn State in Hershey that the blood pressure is beneficial to be high because it's perfusing your brain. How many of you remember the normal systolic blood pressure was your age plus 100? Lee, really? Am I making this up, guys and gals? I can't, right? I couldn't make this up if I tried. So there was no care. Then we developed evidence that said, yes, we can lower blood pressure. We had better agents too at the time, even though we didn't have the renin-angiotensin system initially. And that evolved to an approach called step care, where we recognized that lowering blood pressure was beneficial. And we also then started a care program or care plan, and step care was extraordinarily important because we were starting from ground zero. You got to start somewhere. So step care said use a thiazide or thiazide-like diuretic in everybody first as step one. Remember that, team? Maximize the dose, however long it takes you. If your still blood pressure is not controlled, add a second agent. And if that's not controlled, add a third, fourth, and fifth, stepwise monotherapy titrations. Long time it takes you to do that. And it obligated everybody to be treated with one medication. And we weren't sure that that was okay, but nevertheless, the thiazide-like diuretic was a good choice, as we will see with other clinical trials that we won't discuss. However, that gave way to individualized care as newer agents came available. The renin-angiotensin system, ACE inhibitors, better yet, ARBs. Calcium channel blockers then became available. The diltiazem and verapamils, and then later the 1,4-dihydropyridines and amlodipine, which is the most used CCB in the world right now. So they became available. So we said, well, maybe we should individualize care and give this drug to this person or that drug to that person. But it was still monotherapy. It was still step care with just now you had a little bit more liberal judgment at the first step. You can give one of 4 classes, including beta blockers at the time. And we talked about that this morning as they've fallen out. However, this is really where we need to be, and we are in some places, and even some places in the United States. We need to give way from individualized care to population-based care. We need to approach, or we should approach, hypertension on the basis of a population. But that opens up a whole lot of questions. If you're going to treat the whole population in one way, can you? Or is there going to be differences in demographics, ethnicities, et cetera? I'm going to show you data that there is none. If we do a population-based approach in a proper evidence-based manner. And some of the studies that we're going to review that were done during COVID for the first time has reassured us about that statement. This is my disclaimer. This is an N-of-1 that picked these studies. However, I did bring in all of my colleagues. When we first came up with the idea, I talked to several authorities that I know personally. The New England Journal of Medicine Journal Watch, Alan Brett is the editor. They publish the 10 best studies or landmark studies every year. So I certainly called Alan up first and I said, what 30 did you pick over the last 3 years? Are there any in hypertension? I would be nuts if I didn't do that. And then, of course, I talked to my hypertension colleagues and my society leadership, many of whom, of course, I know. I asked my own hospital system. My hospital system is Prisma out of Columbia. It's also in Greenville in South Carolina. We have hypertension leadership within ours. I mentioned our resistant hypertension clinic. The director is Dr. Riley, and our chief pharmacy director is Emily Ridley. I asked them, did you see any studies that we missed during the last 2 to 3 years? And they gave me some ideas. And then I went more global. I talked to my WHO colleagues, my Pan American Health Organization colleagues, and my American Heart Association colleagues. So it wasn't done in a vacuum, but I have to admit, I made the final decision, and that's it. Whatever it is, blame me. Here's the categories that fell out of this journey, and then we'll talk about them individually. Number one, I've already talked about the importance of a population-based approach. There's some data that came out during COVID that will highlight this and the importance of a population-based approach. New guidelines became available during COVID, particularly the World Health Organization guideline. I was asked this morning after my talk by one of our members an incredibly good question, which is what about the US guidelines, JNC8, the new cardiology guidelines, et cetera? There's some big differences. They conflict. Where are we? And I'm hoping that the WHO guideline, which I'll share a little bit with you, can't do the whole thing, but a little bit with you will spur on some motivation to check it out. Cardiovascular risk prevention has become now a more sentinel in terms of decision-making, as well as patient care. Decision-making, because many of our guidelines now are risk-based. If you have a higher risk, you do this. If you have a low risk, you might consider doing that. So risk prevention becomes important. Then, of course, pharmacologic treatment. And since I've already made the case that the renin-angiotensin system is so important, some of these, of course, are going to involve the renin-angiotensin system, just because it's one of the foundation classes, if you will. Team-based care is becoming so important now. We can't talk about team-based care enough. So we'll look at some new data during COVID for cardiovascular disease, not for COVID disease. Disparities. We always need to talk about disparities. That's job number one. There's some new data on disparities that'll support my statement that if we use a standardized protocol-based approach, using 2 medications that are complementary, we can treat everybody globally and everyone will respond the same. There's new data that supports that. And finally, and this is where I'm on thin ice, I grew up in Boston, and ice can be thin in the winter in Boston, pregnancy. Okay, population. Let's start with this. What happened even before COVID, but this data became available during COVID and might have been just not pushed under the rug, but they had less attention that if it was done in the non-COVID years. In 2020, our last NHANES data was published, and it was drastic, and it was dramatic, and it was bad and ominous. This is our database nationally where we track our hypertension control rates across the United States, and it's equally based on demographics, age, et cetera, race, sex, and we've had it for 20 to 30 years, conducted by the NIH. For the first time in our history of tracking from the 70s to now the 2016, 2017 report, our control rates were going up until the 2013-2014 survey. For the first time, lo and behold, our hypertension control rates in the United States plummeted. This is before COVID. This has nothing to do with COVID. You can go into a million reasons why, but that's the data for the first time. And you can see it decreased from a high of 55% down to 43.7%. And that's using a blood pressure of 140/90 as the definition of control. Less than that for controlled, equal or greater to that for uncontrolled. If you use our new criteria, which we could discuss, of 130/80, that's only 19%. Wow, that's just think about that. When we can control almost everybody. This would be okay if it was just the number, but it's not just the number. We track outcomes in this country. Now they're not cause and effect because they're just population-based numbers. But while the blood pressure control rates were decreasing, what also was happening? Strokes were plateauing and now increasing. And cardiovascular disease morbidity mortality has plateaued. Probably following stroke, it'll take a number of years. I hope it does not go up. So the outcomes are tracking the blood pressure, even though it's not cause and effect. Well, even during COVID, this data was so ominous and had such significant impact on health in our country that Surgeon General stopped everything and said, I need to convene a panel. And he asked for and called for a white paper, a call to action for treating hypertension control in the middle of COVID. And many of us rose to the occasion, including Dr. Patel from the CDC, who led this. And it came up with 3 goals. 1, make hypertension control a national priority in the middle of COVID. 2, ensure that we talk about hypertension and blood pressure everywhere we touch in our social and community lives. And more importantly, 3 was optimize patient care and patient care control by using a standardized protocol with a standardized formulary that is small and globally and or nationally applicable to everyone within the country. This is right out of the Hart's playbook. That's where this came from. So that's our population-based approach. Even during COVID, we were asked to think about guidelines because the guidelines were so different, controversial. One society said this, another society said that. The WHO asked and said, why don't we convene a panel during COVID that will develop a global-based hypertension guideline recommendation for blood pressure. And that means you have to convene about 25 or 30 people from around the world, which we did. I was co-chair of this guidelines committee, and I was co-chair of the writing committee. And then you can see the publications in hypertension, again, in the middle of COVID. Dr. Zalamaki, myself, and Paul Welton at Plumtree Lane. And there were 3 issues that these guidelines discuss. We don't have time to discuss the guidelines, but I want to make you aware of them. So I think they're extremely appropriate for all of us today, and they're extremely fair. Blood pressure threshold, when to start treatment. And also, if you're going to start treatment, when are you going to stop? What's your target? Do you need testing? Or do you need cardiovascular risk assessment before starting pharmacologic therapy once you've made the diagnosis? Also, what drugs are we going to use? Are we going to use them in the individualized approach or a population-based approach in terms of combination therapy? That was one of our goals and criteria to deliberate on. And whether non-physician community health workers or nurses or pharmacists can also dispense medications and control blood pressure in a team-based approach. There were 8 recommendations in these 6 domains. And just by coincidence, in Hearts, we were developing a global-based hypertension clinical pathway. And that's right here. It's on 1 page. If you take anything home, take this page. It has all of the key elements to it in terms of I will call a new way or a population-based way to consider treating your hypertension patients or your patients with hypertension. It's got 3 modules, and it follows exactly the recommendations from the World Health Organization, as you might expect. And I'll highlight some of those. We were asked this morning about taking a blood pressure. How do we take it? How poorly do we take it? How can we do it better? It's number one. It's A on the hypertension clinical pathway, how to measure an accurate blood pressure. Lo and behold, that's how important that question was this morning. And you can see there's posture, there's ways to seek the patient. Validated is on there if you can read it. I'll use a validated device like we discussed, etc. And obviously do it in a quiet, unobserved manner if you can. Second, risk factor analysis. Whenever we can, whether it's a lab-based algorithm or a non-lab-based algorithm, determine cardiovascular risk. However, one of those recommendations from the WHO was don't let that stop you from starting pharmacologic therapy once you've made the diagnosis. Not as important for us because we can get labs very quickly, et cetera. But remember, these are global recommendations. What if you're in Bangladesh? What if you're in Vietnam? What if you're in Guyana? Can you get labs? You could draw them and send them someplace, but are you going to get them back in a timely manner? So do not stop or wait to use hypertensive medications while you're waiting for a risk analysis and or laboratories. You don't need laboratory data to start antihypertensive therapy. Obviously, it's recommended to obtain. C is the heart of the clinical pathway, and that's the protocol. As you can see, it also tells you when to start blood pressure medications. It's 140/90 for the WHO and the general population. But if you have diabetes, chronic kidney disease, you already have a cardiovascular event, or you have high risk, it's 130/80. Follows very similar to the AHA-ACC guidelines of ours. And that's in that panel, that quadrant right up there. Tells you when to use a statin, when to use aspirin, and better yet, when not to. And then it goes, then the algorithm. You look at the algorithm, this is just an example. It starts with a long-acting ARB and a long-acting calcium channel blocker, telmisartan and amlodipine at half maximal dose. The minute you diagnose the patient with hypertension, you give both, preferably in a single pill versus two separate pills if you can. We'll talk about that. And then within 2 to 4 weeks, you step up that regimen, you double the dose. If you're not controlled, you add a third agent. In this case, it's a thiazide-like diuretic. Half maximal dose, you double it again. And then you either can refer or you can add a fourth line agent if you're still uncontrolled. But our data is absolutely uncontroversial. 85% to 95% of our patients, no matter where we've started parts, has been controlled using this approach with 3 antihypertensive medications. We just have to be more aggressive, assertive, et cetera, and get over clinical therapeutic admission. And then lastly, we did think about, we're in the middle of COVID. We have vaccination recommendations there as well as how often are you going to see them? Once you're controlled, every 3 to 6 months, depending on your risk, your cardiovascular risk, every 6 months if you are controlled, and you're the general population. And there's a disclaimer that, of course, you're not going to use RAS inhibitors, either ACEs or ARBs, if you have a childbearing woman that's of childbearing potential, either actively trying to become pregnant or already pregnant, of course. This says it all. And this is right out of the 8 guidelines recommendations from the WHO. Okay. Next paper. And this is now in risk, cardiovascular risk category, if you will. There was a paper during COVID 2023, right at the tail end, trends in providing medications and lifestyle counseling. We talk a good game. We know you're supposed to use statins and all of these, at risk and already risked patients. We know you should give lifestyle counseling in everybody. Somebody asked me a question right after my talk about lifestyle modification. You start that in everybody, even if they don't have hypertension, right? But you don't wait for pharmacologic treatment while you wait for lifestyle counseling to have an effect. So that's the only recommendation there. Well, how often do we do that? Do we really, do our actions meet our words? And that's what this study aimed to prove, or at least look at. It was a cross-sectional study. It was our study from the US National Ambulatory Care Survey. It was adults, age 21 years or older. And this is important, these are individuals with atherosclerotic cardiovascular disease. They must be on a statin unless there's a contraindication, et cetera. No question about that. Well, how well did we do? They should be on an aspirin as well. And also, obviously, they should have lifestyle counseling. Well, are you ready for the bad news? And we've met the enemy, and it's us. I think that was an old pogo. cartoon somewhere. Those of us that are old enough to remember Pogo. We're dismal. This is all three: lifestyle, counseling, statins, and aspirin use. And you can see it's been flat. This is pre-COVID, so we can't blame anything else for it but us. We know it's in guidelines. We're just not doing it. So we really do need a call to action regarding that. Regarding, we know to use these agents, we've got to use these agents to a greater extent. So with this study, then, what's the conclusion? We've already kind of given it away. Since 2006, modest increases in statin and aspirin, we're talking about percentages, not wholesale increases. And lifestyle counseling has actually decreased, not increased. And I didn't show the other data, which is disparities of care is significant. Blacks and females lagged even further behind. So the clinical implication is we got to get with it. Greater emphasis and population strategies are desperately needed so that we can turn the curve further upward on all three, in addition to medication prescribing and, of course, blood pressure control. And it's not just blood pressure, it's just good health, it's diabetes, it's cardiovascular disease, et cetera. Okay. When I travel around the world and we develop protocols that are going to be globally based, one of the first questions I get is what time of day should we give the medications? There was some data from Spain several years ago before COVID that showed that if you dose antihypertensive medications at night, you had dramatically improved blood pressure control and outcomes. That data has been questioned. It's been questioned as it's possibly flawed, and it's been withdrawn. However, we still didn't know the answer. Is it night, day, split them, or what? The time trial was ongoing in the UK during COVID, and it asked that exact question. Does time of day matter when you prescribe antihypertensive agents, whether you give it in the morning or whether you give it in the evening? And that's what they did. Two groups of individuals with hypertension, they were already on medications, and they split them up. Some took all the medications in the morning, and some took all the medications in the evening, and of course they were once a day medication, so there wasn't a problem there, and they looked at cardiovascular outcomes. Just look at the right-hand panel on the slide, and you can see the two curves. One's night and one's evening. I don't even care which one it is. There was no difference in terms of cardiovascular outcomes over the length of the time trial, and it sort of puts that question to rest. There was no difference in any sub-endpoints either, stroke, and angina, MI, et cetera. Just frankly, no difference. So what do we conclude from the time trial, and how does it change our clinical practice or help our clinical practice? Patients can take their regular hypertension medications at any convenient time of day they want. So that's the bottom line. That's a good thing. So what's the implication? It brings clarity finally to this debate. I think it ends the debate regarding nighttime dosing versus daytime dosing. They're both okay. However, most importantly is once a day. It's key. And it also then gives us flexibility, our patients flexibility, and it gives us flexibility. So time of day doesn't matter as long as it's consistent and they're once a day. This brings us to the discussion this morning. There's obviously, we have ACEs and we have ARBs. Our ACEs are older. We've had much more experience with them. We're kind of like wedded to ACE inhibitors, and that's natural because we've had such time using them and comfort, both patients and physicians and healthcare professionals. But are they the same? Are there differences between the two classes that we're not aware of? So this is the safety of ACE inhibitor and ARBs in hypertension study published in 2021, again, right during COVID. Again, I'll read that. ACEs have a longer history. Both are equally recommended, but is there one better than the other, or they're the same? We just choose our preferences. So the study included, was multinational. It was retrospective, patients with hypertension on monotherapy with either or. So they had to be on only one medication, an ACE or an ARB. And you can see there was a lot of patients, a couple million patients on significant numbers in both. Well, was there any clinical difference between the ACE inhibitors and the ARBs in these individuals with hypertension? And the answer is no. You can look at the graphs, you can just look at the dots. They're all the same. They all on the right, smack in the middle of the line. So there was no clinical outcome differences between the ACEs and the ARBs. That's good, because there was some older data that said, well, maybe the ACEs are more effective than the ARBs. That's no longer, that will no longer hold true. They're absolutely equal for all cardiovascular events that you want to look at between ACEs and ARBs, as we discussed this morning. However, what wasn't equal was the safety profile. ARBs had significantly lower risk of angioedema and cough. Now, I kind of don't know. I feel bad if you cough. That's just a cough. But I feel really, really bad if you have angioedema and you're in the ER and you have a mortal effect. So we have to do some introspection. There's reasons to use ACEs. Cost, availability, et cetera, is always important. Better to take a renin-angiotensin inhibitor than not take one at all. But if we have a choice, ARBs over ACEs. And that's where the recommendations came from the HEART study and the hypertension clinical pathway, and that comes out of our paper from 2019. That put ARBs over ACEs in our hierarchy of prescription factors. So, conclusion, within the class of renin-angiotensin system inhibitors, there's equal support of prescribing either or ARBs over ACEs, except for safety. So ARBs win over ACE inhibitors, again, if they're available, affordable, et cetera. And of course, this is also recommending long-acting ACE or ARB use. Clinical implications, it strongly supports the recommendation of ARBs in treatment protocols if we're going to standardize a protocol globally, or even in our community, or even in our practice. It gives us the evidence base now to strongly prefer an ARB over an ACE, while still supporting the use of ACEs when that's the only medication we can get. Another frequently asked question that has now been answered is, well, what about the thiazide or thiazide-like diabetics? Remember, they're one of the three rocks of our prescribing armamentarium for hypertension: RAS inhibitors, thiazide-like agents, and CCBs. Well, within the thiazides, we've had a long-standing discussion about which thiazide. Hydrochlorothiazide is the one almost all of us use, and it's just been ingrained in our treatment patterns. We don't even know how that happened, because chlorthalidone came first. And there's more evidence based with chlorthalidone than there was with hydrochlorothiazide, since it was the first one. But nevertheless, we're using hydrochlorothiazide. But there's strong rationale for chlorthalidone being better than hydrochlorothiazide, and that is it's longer acting. So it lasts once a day. Hydrochlorothiazide only lasts 6 to 8 hours. You get greater natriuresis. You get greater blood pressure reduction with chlorthalidone over hydrochlorothiazide. So this came up again in the HEARTS program. If we're going to develop a protocol or a program that's going to be applicable globally on a population basis, we should pick one if we could. And which one, if that's the case? Well, we have this new study that just came out, New England Journal of Medicine in 2022. Again, right in the middle of COVID, and it asked that question. Chlorthalidone has a longer half-life. It lowers blood pressure greater than hydrochlorothiazide. But what's the effect on cardiovascular events? What's the outcome? Those are surrogate outcomes, right? The VA, we owe them a debt of gratitude. They did this enormous study in our VA system, 13,000 patients. They were older, greater than 65 years of age, and they split them into two. Patients with hypertension, one group got hydrochlorothiazide at the 2 recommended doses, half maximal, 25 milligrams or 50, if they still weren't controlled. And the other group got chlorthalidone at 12.5 or 25. It's twice as potent. That's why the doses are half, but they're equally potent doses. And the primary outcome was cardiovascular events. What happened? The first thing that happened was there was no difference in blood pressure control, shown on the left-hand panel, between hydrochlorothiazide and chlorthalidone for systolic blood pressure or diastolic blood pressure. That's going to become important. Remember, the physicians were able to use other medications to lower the blood pressure at their leisure. There was no goals for that therapy. That was just standard of practice. Well, it turns out it did a very, very good job. So whether they used hydrochlorothiazide or chlorthalidone, the blood pressures were the same. The potassium levels weren't, as we're going to see, but the outcomes were not different between the two. So there was no difference in cardiovascular outcomes. For the first time, we have evidence based on outcomes between chlorthalidone and hydrochlorothiazide, based on the VA study. And this is the endpoints. As you can see, these are the demographics. It didn't matter if you were black, white, etc., young, old, had CKD, didn't have CKD, etc. Everything was the same. But there's going to be one caveat I'm going to end with. There was more hypokalemia with hydrochlorothiazide, but it didn't lead to hospitalizations, but it was noted. And that's understandable because it has a longer half-life than hydrochlorothiazide. That would be expected. So what was the conclusion based on this study? Patients receiving chlorthalidone did not have lower cardiovascular events. That would have been my prejudice or my bias. I would have thought it would have lowered blood pressure better and it would have had lower cardiovascular events, but it didn't. So what's the clinical implication for all of us practicing? You can use either as long as you control the blood pressure. The blood pressure is the most important thing. So providing blood pressure is controlled, either hydrochlorothiazide or chlorthalidone is appropriate. Within that class of thiazide-like diuretics of all of our guidelines now that recommend that one be one of our three primary classes. I think that's reassuring to all of us, but remember the caveat. Blood pressure has to be controlled. If it's not controlled, if the chlorthalidone lowers it more in your population than hydrochlorothiazide, it probably would be better, but we don't have that evidence, of course, but that's just intuitive. Another question that comes out when you do a population-based approach and you develop an algorithm, again, for global applicability, even for the United States applicability, is if we're going to start with 2 medications, if that's going to be our recommendation, which it is, at half maximal doses, I'm going to drill that into all of us repeatedly. Is there a difference between using 2 single pills, or should we really, really try to talk to our insurance companies or policymakers, et cetera, to do fixed dose combinations or a single pill where both of those doses are in a single pill? Is it worth our while to advocate for that, if you will? Because it's a little more costly. Okay, that's what this study did. This is the START trial. That's the only question it asked. Does giving combination therapy in 2 separate pills any different than if you gave it in a fixed dose combination in 1 single pill? So multi-dose, multi-pill versus 1 single pill. Is there? And to do that, what they looked at was 60,000 patients, aged 18 or greater, adults. So they either were on a single pill or 2 different pills of the same drug, the same medications and the same dosage. The only difference was 1 pill versus 2 pills in terms of the study. They looked at 4 different combinations just to make sure there wasn't any combination variability. That was pretty impressive. I thought I would have probably taken the easy way out and just done 1, but they did 4 different combinations, as we're going to see, and they followed outcomes. This is dramatic. I didn't expect this one. I knew I was biased to a single pill, meaning the fixed dose combination pill, but I've never imagined it was this important. Here's your outcomes. This is all-cause mortality for 100 patient years on the upper left-hand panel. And these are some combinations that they chose. Valsartan and amlodipine. Oh, really? An ARB and a CCB. That sounds good, right? We've been talking about all day. Candesartan and amlodipine, an ARB and a ramipril-ACE inhibitor and amlodipine. Okay. And this is really interesting. They did have a smaller group that had 3 medications in 3 separate pills or 1 fixed dose combination of valsartan, amlodipine, and hydrochlorothiazide. They looked at that too, but it was a much smaller group, but they included it. Look at the difference in all-cause mortality. The single pill is in black, and the multi-pill is in the light gray. Dramatic differences. Reductions in mortality using the same doses, the same medications, but in a fixed dose single pill versus 2. Why? Adherence. That would be the likely explanation. I've been lobbying, and Dr. Carter mentioned even last year, I was lobbying to get us to start 2 medications upon the initial diagnosis at half maximal dose, but beware, it's coming. How about 3? How about 4? And instead of half maximal dose, why don't we do 4 at quarter doses, called the quad trend? The data is already extremely impressive. And this is telling us why. There's a little snapshot of the 3 medications, there was no mortality in the single pill, in the fixed dose combination versus giving them in 3 separate pills. Again, it's just wets a little appetite. It's coming. So what's our conclusion? Single pill or fixed dose combinations have lower incidence of cardiovascular events and actually mortality. I don't think any of us would have expected that too. It's that impressive in clinical practice and should generally be preferred. That means we're going to have to be a little bit of an advocate. Chris and I have been talking about advocacy. What does it mean? What's the definition? It's in the beauty's in the eyes of the beholder. But here's one where I say, if it's a little bit extra money, we should then pressure our whomever's making the decisions to help us with single pill combinations, fixed dose combinations, and we're doing that globally as well. We're talking to health ministers of all the countries and anybody that'll listen to spend that little extra money, and they don't have much money, remember, because of this type of data. So strongly supports our current treatment protocol, the one I showed you, in our hypertension clinical pathway, even though that protocol was developed before this evidence-based, it happened after, to start 2 antihypertensive agents, half maximal doses, in 1 single pill if you can. Team-based approach. Can we do better than what we're doing now? Whatever that is. And it's all a mixture of things that we're doing, differently. It's not standardized for sure. But does team-based care matter? This is an impressive study. Came from China, a community-based program out of China, published in Lancet in 2023, just this year. And it asked the question, what's the effectiveness of a non-physician community-led provider, intensive blood pressure control program? Does it work? Is it better? Is it worse? It could be worse than a physician-led. Now, it was physician supervised. The protocols were developed by physicians, by teams, and then the protocols were disseminated to the non-physician-led team-based care program. It was healthcare workers, nurses, pharmacists, et cetera. Anybody that would volunteer to join the team. Again, a huge study. China, 326 Chinese villages participated. They split them into 2 groups, the team-based care group and the control, the patient standard, whatever the Chinese practice was at the time. And they looked at cardiovascular outcomes. So team, non-physician led, physician supervised, but non-physician led versus their standard of care, what was ever the standard of care in these Chinese villages. Wow. This is the blood pressure reductions in the 2 groups. In red is the usual care group. And you can see systolic blood pressure and diastolic blood pressure. And actually, not that bad. But look what happened with the team-based approach. The physician supervised but non-physician provider-led group. Look at the dramatic reductions in systolic blood pressure and diastolic blood pressure to the tune of about 127 to 72, 73 in the team-based care led group. Dramatic. This study is getting all over it's all over the place. And it's a good wake-up call to all of us. But it's even a more important wake-up call for some of the countries I go to in our Hearts program. You cannot do non-physician-led team-based care. It's illegal. I mean, there's legislation against it. So we've had a lot of resistance at the health ministry level, at the political level in some countries, and that we've got to break those barriers down. But it's data like this that now gives us some armamentarium. This is also look at the endpoints. This is incidence of cardiovascular disease. Remember, blue is the team-based care, lower. Stroke, dramatically lower. And they were still widening during the study. They didn't level off and then equalize. They were still getting wider and wider and wider. And then all-cause death was significant. So, conclusion of the team-based care study, non-physician community healthcare provider-led intensive blood pressure intervention works and is effective. Now, this is in 326 Chinese villages, and it needs to be duplicated elsewhere, but this is really good news. It strongly supports the recommendation of the WHO guidelines in all of our societies now for team-based care approach, not only to hypertension, but all other disease management, if you will. And antihypertensive medications can be dispensed by non-physicians under physician supervision. That's in the WHO guideline. That's recommendation, please. And it took forever to get consensus on that one because we had 30 people in the room from 30 different countries around the world. So we came to consensus. That was before this publication. Okay. Disparities. Equally important, if not more. We all know in this room, there's a tremendous disparity in hypertension control rates, hypertension outcomes for given levels of blood pressure, for given levels of age. Blacks are significantly worse off than whites. No question about it. We've known this for decades, but can we do anything about it? What are some of the barriers? We might not be able to address all of them, but maybe there's some barriers we can. This study comes out of the Kaiser Permanente group. You've heard Regna mention the Kaiser Permanente team in ID and COVID data. They do excellent work also in non-communicable diseases. And they've had a hypertension control program over the last 15-ish years, maybe 18 years, where they've used a team-based approach. They've used initial combination therapy from complementary classes. In fact, it's a lisinopril hydrochlorothiazide combination, which they've stuck with. And they have the longest data, and they track data meticulously. But they asked another question. Does this approach help disparities of care? Does it kind of equalize or even semi-equalize disparities of care? Because again, if you use two medications from complementary classes, you will lower the blood pressure the same in any demographic group that I'm aware of. And that we have significant data on. So that's what they did. The issue was greater percentage of blacks compared to white adults with hypertension have uncontrolled blood pressure. Their control rates are poorer. So their outcomes, of course, are going to be poorer. But then again, that's not the reason. The study examined, though, changes in blood pressure control before and after what they called a QI, a quality improvement program. What I'm going to call is a population-based approach to hypertension. Again, with two medications, same time, standardized, team-based care, everyone gets the same protocol. With rare exceptions, of course, if you don't tolerate medications, et cetera. This was done in the Kaiser Permanente Southern California branch, but they got millions of patients in the northern branch, and they got millions of patients in the southern branch. So this was the southern portion of Kaiser. Again, it was conducted over an 11-year period, right up to the COVID period. And they used a preferred medication algorithm of lisinopril and hydrochlorothiazide first at half maximal doses. It was 20-25 of lisinopril and hydrochlorothiazide, and then they titrated it upward. The outcomes were, can we increase blood pressure control? Can we level the playing field? Can we improve disparities of blood pressure control? Outcomes will take another couple of years, but they're following outcomes too. This was just published. As you can see here in JAMA, there's the paper from the Kaiser Permanente group on the left and the measures on the right. It was significant. If you look at national data of blood pressure control rates from the NHANES database, there's a 15% gap between blacks versus whites nationally. And also, if you look specifically at control rates, it's 80% to 37%. There's a huge gap. They controlled this gap to 3%. Still a gap, and still we need to do better. But I would tell you that's a whole lot better from 15% to 3%, and they're still working on why isn't it zero? Well, there was no difference in clinical visitations. They came to the visits the same, so that wasn't good. Access is free. Remember, it's an HMO, et cetera. They intensified the protocols the same, and follow-up for the elevated blood pressure was the same. So what did it come down to? Their first data set looks like it was adherence. That's still, adherence is lower in our black population versus our white population for reasons that we don't understand, but we need to find out the reason. But it's dramatically better using our approach, the standardized population-based approach, again, in all demographics. By the way, they've done this in Asians. They've done it in whites, of course, and they've done it in Hispanic individuals. The control rates are the same using this protocol in all these different demographic groups. So there's the clinical implication. It reinforces the core foundation of our hypertension population-based treatment protocol approach. Okay, let's end with pregnancy. This is not my area of field, so if there's any OB gynecology people that chime in, please, and help me out. But there was a land-breaking study during COVID on hypertension in pregnancy or during pregnancy. And it was a treatment of mild chronic hypertension during pregnancy trial, again, published in 2022. What it did was, prior to this study, ACOG, the ruling body of our colleagues in OBGYN, recommended antihypertensive medication in chronic hypertension during pregnancy at a blood pressure of 160 over 110. Now, there, this is an eclampsia. This is a preeclampsia. This is hypertension and elevated blood pressure during pregnancy, and that's the guideline. 160 over 110, start pharmacologic therapy in the absence of other, obviously, comorbidities. But the question always has been, our other our non-pregnant population, we know the threshold should be lower. But what is there anything special about pregnancy? And if so, but that's okay. So that's what they asked. 2,400 patients were studied. It was published in the New England Journal of Medicine. And there was two groups. They were randomized to two groups, one 140 to 160, and then one to less than 140 over 90, which is the intensive treated group, as you can see. So they were randomized. This is hypertension before 23 weeks. So this is hypertension during pregnancy, not pregnancy-induced hypertension. And the primary outcomes was pregnancy outcomes, preeclampsia, preterm birth, abruption, etc. What happened? What did we find? Or what did they find? The intense care treated group had a blood pressure of 130 over 79, and the control group had 133 over 82. First of all, they were already treating blood pressure more aggressively than the guideline. Kudos to our colleagues, our OBGYN colleagues, but there was a significant difference between those two blood pressures. The outcomes were 30% in the intensive treated group and 37% in the control group, highly significant. The conclusion was treating lower blood pressure in mild chronic hypertension during pregnancy improves outcomes, treating it to a lower target. I've never seen this before. Overnight, after the publication, there's embargo by the New England Journal of Medicine, but the day of it's published, you can discuss it. That night, they convened and they changed the guidelines. That night. Immediately changed the guidelines now to treat mild hypertension during pregnancy with antihypertensive pharmacologic agents, now to less than 140 over 90, and that was instant. That's what we should be doing. So let's summarize these trials during the pandemic, and we can discuss them, because we haven't had an opportunity to discuss them until now, because we haven't been in person. Despite safe, effective, and available and affordable antihypertensive medications, we're still doing a pathetic, if not dismal, any word you want to use, job. We must do better. We can do better. We know it works. Recently, several key trials have been published that have clear clinical implications where we should immediately change the practice of our management of hypertension. Hypertension diagnosis and management must be continually reviewed and changed when new evidence becomes available. We have to be open-minded. Sometimes we're not as open-minded as we could be. And these landmark studies support a population-based primary care driven approach to the management of most with hypertension. Remember, there's always exceptions. We're talking about the patient rule, not the patient exception. The patient rule is 80 to 90% of our population. That's the population we're treating. There's always exceptions, frail elderly individuals that you suspect have secondary hypertension, et cetera. Multiple comorbidities, where we need our specialty colleagues side by side with us. That's what they're there for. But the bulk of hypertension management and control is primary care driven. And I'd like to make a passionate plea for us to change our approach to a population-based approach, whether it's in one clinic, a system, a region, a state, or globally. Thank you very, very much for having me.
Eddie, for a wonderful presentation. Any questions? from our audience members.
Yes. Yep. Mhm. Yeah. The question again, and we mentioned it, but only in passing this morning. You're right. Let's spend a couple minutes on that. It is still such a frequently asked question. What's the role of beta blockers? What's the place of beta blockers in the treatment of our hypertension patients? As I grew up, even before RAS inhibitors or renin-angiotensin inhibitors, they were the bulk. That it was beta blockers and thiazide diuretics. That was our class. Then you had clonidines and albumets and guanethidines and the serpines and you name it, before we had calcium channel blockers and RAS inhibitors. Now with RAS inhibitors and calcium channel blockers, in addition to our thiazide and thiazide-like diuretics, there's enough evidence, although it's not solid evidence, that beta blockers may lower the blood pressure, but they don't lower stroke rates. But that level of blood pressure reduction would predict. So let's say you lowered it 10% and you should have lowered stroke 4%. You only lowered 1%. So there's a disparity there in terms of blood pressure reduction with beta blockers and reduction in stroke. So for that reason, they're not recommended. They're not on that. Remember this morning I showed the triangle with the three classes. Calcium channel blockers almost solely will be amlodipine, because that's the #1 calcium channel blocker that's prescribed globally, including in our country. The RAS inhibitors, we talked about ACEs and ARBs. They're equal in all parameters except safety. Angioedema and cough, which favors ARBs versus ACEs. And the thiazides and the thiazide-like diuretics, you have the longer-acting thiazides like chlorthalidone, the shorting-acting thiazides like hydrochlorothiazide. And if you lower the blood pressure the same, the study that we just went over, the new study shows that you could use either one. But that's the rationale for the beta blockers. So we don't even use them fourth. Remember the Pathway 2 trial we talked about, you use spironolactone, you block aldosterone. You could add the beta blockers for all other reasons, migraines, MI, congestive heart failure, absolutely, for comorbid, but not specifically to lower the blood pressure. And I think most guidelines now have those three as the triad. Other thoughts? There's a question in the back, Randy. The beta blocker question is really, really hard. And it's really, really hard for me because I went through the beta blocker era like all of us when we didn't have anything else. And we got so comfortable with beta blockers. Yeah. And they do a good job on so many things.
Any benefit to keeping your potassium above 4 for people with hypertension? And then what about using diuretics in the geriatric population?
Yeah,
I have plenty of patients. We keep them on the diuretics. I just said not, and they've done really well. But is there any more information on that?
Yeah. Two questions. Thank you for the potassium question. There was no new study on potassium, or I would have probably brought it forth to us. The question is there a role for potassium? You mentioned potassium level being higher, but the broader question is there a role for dietary potassium regulation, for raising our daily potassium intake, our total body potassium, and maybe even the serum potassium level? That's controlled by homeostatic mechanism. We always talk about sodium. Salt, 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 salt. Absolutely appropriate. We've been beating sodium to death, and it's for good reason. Lower sodium lowers blood pressure on a population-based approach, as well as in certain demographics even more. But we haven't talked about potassium. They are integrally related in an inverse manner. There was a person by the name of Lou Tobian from the University of Minnesota 40 years ago. Lou was in college. I was young. He was one of my the people I looked up to. He did some dramatic studies in rats, and he gave them extra dietary potassium and showed it lowered their blood pressure. And more importantly, it prevented stroke. But it didn't get any traction in rats. And we didn't relate it to humans because we were really all encompassed on sodium. The answer is yes. I don't know about the serum potassium. I don't think we have to go that far. because that's going to be controlled by hormonal mechanisms, but dietary potassium is critical. And it's in the opposite direction. More is better. Less sodium, more potassium. So for a given level of sodium ingestion, if you increase your dietary potassium, you're going to lower blood pressure. That's been shown. No matter how you do it, if you do it by dietary potassium, or in fact, what if you gave a potassium sparer, an agent just to spare the potassium and raise the serum potassium? The Chileans have done that. Morbidity, mortality goes down. So potassium is as crucial as sodium. It can't replace sodium, but it's as crucial. If you come from South Carolina, my guess is North Carolina is not that different. We're pathetic. Our dietary potassium levels, for whatever reason, are extraordinarily low. My colleagues tell me that are South Carolinians is because we boil our vegetables, our greens. The potassium's in the water, and they eat the greens. But you'd be better off drinking the water than eating the greens. Frying it, absolutely perfect. There you go. I like that. So anyway, yes, it's the ratio. So now what do we do? In our clinics, it's cheap, it's easy. We measure urinary sodium and potassium. Start doing that on a couple patients and you're going to be shocked. The urinary sodium will be high and the urinary potassium will be low because they're not eating any potassium and they're eating a lot of salt. Flip that ratio by either increasing dietary potassium, reducing dietary sodium, and even maybe you could use medications. I'm not espousing that yet, at that level yet, but potassium is critically important. So we need to increase our dietary potassium. And in the recent guidelines, by the way, it's the first time it's been mentioned. So yes, potassium is good, sodium is bad.
I just want to know what potassium dose will you recommend in terms of supplementation?
Okay, but I have a follow-up question then. For what entity? Why would you want to use oral potassium? Is it heart failure or just because it's low, or the potassium? Potassium supplementation?
Because you just said
Yep.
potassium, we should increase potassium. So that's
Right.
what I'm thinking.
Yep.
Because I know some patients who are maybe 99
Mhm.
micromilligrams.
Right. Well, we're not recommending oral potassium supplementation.
Oh, okay.
Dietary potassium supplementation. Why? You'd have to give a lot of oral potassium supplementation to equal what you could get in your diet. So we're not recommending oral potassium supplementation. It's too short out. It's too small amount, and it's too short out. It's too short. So dietary potassium would be the number one way to go. Increase your foods, greens, etc., that are rich in potassium, and don't boil them, fry them, or do whatever else, but just don't boil them, or drink the water. And or also when you use a potassium sparer like spironolactone, we talked about the aldosterone receptor antagonist and mineralocorticoid receptor antagonist. They raise serum potassium. That gets back to your question. That's a good thing, as long as it's not really, really high. It actually might be beneficial. And that may be one of the reasons why spironolactone works, by elevating total body potassium, because it's stopping potassium excretion. So it's raising your total body potassium. Yep, fruits and vegetables. There's Lee, and greens, but fried. So we have a terrible problem in South Carolina. It's just our diet, culture, etc. And I have a terrible problem because I'm an Army brat and my father never ate vegetables. It was just meat and potatoes. So I'm doomed. I blame it on my dad.
What do you do with a long QT syndrome hypertensive who may or may not have coincidentally developed a long QT after initiation of 40 milligram ACE inhibitor?
Sure.
So what are you going to do for their medication regimen, please?
Obviously, you might want to decrease it. If you think it's the medication that's inducing the QT prolongation, then obviously you would lower the medication or eliminate it. Yeah, that's all you would. That's such an ominous, possibility, because now we're talking about sudden cardiac death. That would be an exception. But nevertheless, it's real if it's your patient.
So how about the hydrochlorothiazide, the spironolactone? I mean, where are we going to go with this person?
I would probably say spironolactone first, because it wouldn't lower serum potassium, it would raise serum potassium, but that's not my absolute area of specialty. I would consult, but it's so rare. That's why our colleagues are so valuable. That phone would ring off the hook to my EP, my electrophysiology specialist. And I say, I've got this really, really unusual patient. Help me. Forget this DiPette guy. There was also a question over here that I didn't answer the second part of your question, so I don't believe. We talked about the potassium. The second part was? Oh, yes. Also important. Remember, when we talk about a population-based approach, we're talking about the patient rule. I've said that before, not the patient exception. But the patient exception could be any age. In our elderly population, we don't recommend any differences based on age, but every individual is different. We know our elderly population, they develop more hyponatremia to thiazide or thiazide-like diuretics than our younger population. They have reset osmostats in the brain, in the medulla that regulates osmotic level. So they have a reset osmostat at a lower level. So if you use a diuretic, they're going to drop their serum sodium and their osmolality is going to go down. We know that. Most of the time, that's not clinically significant. It might go down to 132, 133, but when it goes down to 108, 110, we have a problem. But that's the exception, not the rule. So age alone shouldn't impact that. Keep the thiazide-like diuretic at the lowest level you can. And obviously in our elderly population, especially our elderly frail population, monitor electrolytes more often than you would in a younger population, but it should not change a population-based approach just on age-based alone. So I don't know if that helps you or not. But we don't have any age recommended. The other option is, of course, the other alternative is, which is not an alternative, it's a recommendation. Use your thiazides third in that line of order, your ARBs and your CCB first, maximize the dose, and only then, if you need additional blood pressure lowering activity, add your thiazide or thiazide-like diuretic at the half maximal dose. I just came back from India, and I learned a lot. In India, they have a terrible problem with hyponatremia and dehydration with thiazides in India because of their climate. And I didn't know this, but it was an eye-opener to me. So they use actually smaller levels of thiazide-like diuretics than we do. They will start with quarter dose thiazide diuretics, but again, that's the exception. They know their population, their climate, et cetera. And they taught me. I wasn't teaching them.